It's our question of the day. What does all this have to do with rural, right? And so we're watching as OBs are closing throughout this country. And so too follows their community hospital, once you're obstetric. So we've studied it for a decade, and we've looked at it. And the danger of that is significant. Take aside just, okay, we can't provide good quality health care, life-saving health care. Economic engines that we serve as rural hospitals to our communities. Wipe that away. Donations, access back, all of the things that we represent in rural healthcare, which is really all dismissed in the understanding that, no, you're gaming the system. And that phraseology has been used so rampantly, gaming the system. States are gaming the federal government. No, it's been going on since the 1980s. It's allowable. It's providing a provider tax, which allows us to capture enough money to cover the cost of delivering service to the Medicaid population. But that's really what's at heart here. You'll have congressional leaders go out on their talking points and say, we did not cut Medicaid to the mom and dads that need it. Well, you're cutting the reimbursement to the hospitals, which means there will be no access. So we're giving everybody a new car, but you're not going to have any gas to drive it. Yeah. And this is exactly how they're tying our hands. And yet we're the bad guys. And so we're going to start to play that out. But then the answer came from Congress saying, hey, stop belly aching, JJ. You got this rural transformation grant. That's going to save all the issues and problems. Reminder, they took away $1 trillion, gave us back $25 billion, basically, 50 divided by 2. And now we're finding out the funds cannot be used for replacing any of the losses from the provider tax. That's explicit. Cannot be used for any purposes. And then each state gets to design their own application, essentially, of what they want to see. So I bring us back to that issue because it's heavy on the minds of many people. I go and I speak to different folks in the community, and they say, but you got that other money to keep your hospital open, JJ. I don't even know if I'm going to see that money, Dr. Shepard. So you've had a chance to work with us to see some of the work that we as an MHA, Michigan Hospital Association, put forth by rural CEOs that served on that committee. You were on a committee panel with us presenting at one time. Well, the department just finally released their report and their application, which we did not get to see before it was submitted, by the way. 60 pages in length, creates a lot of committees, a lot of subcommittees. What's your take on this? And is that going to sustain our hospitals?
It's a good question. So I think the first thing is, my guess is that for most members of the public, billions, trillions, those are just big numbers.
They are.
And so it'll be easy for politicians to distance themselves from the cuts, which is, I think, the design.
Yeah.
And for most people, that'll be hard to understand. Well, you got all this money from Congress. Where did that go?
Where'd it go? Yeah.
I think that also fits into a public narrative of companies that are taking public dollars into their own private coffers rather than providing healthcare access, which is not true. I try to remind people, like, rural healthcare is not a particularly profitable entity in general. It's something that you're already scraping by in many cases. And it's a service to the communities in which it's operating. Your people that are involved in rural healthcare are doing it because they care about rural healthcare. And so to sort of view any of this as waste, fraud, and abuse combatants are offsetting the expected losses from Medicaid, I think is really not true. The Kaiser Family Foundation suggests that only about a third of the expected losses from Medicaid can be offset by the bill or the transformation fund. The problem is in the actual details of the transformation fund, they essentially forbid money from being used for that purpose. And so even though I think you can still hear members of Congress refer to this as the Rural Hospital Fund, the Rural Healthcare Fund, there's actually really strong limitations on how much of that money can go to rural hospitals in general, which I think was unanticipated and has allowed a bit of a bait and switch. The application itself for Michigan, so I've now read about 15 states' applications.
Okay.
About 35 or 40 are publicly available now. I would say Michigan's application is in some ways similar to other states and in important ways different from some of our peers. So the things that I think are well, one of the things that's concerning for me is the number of initiatives being pursued is taking an already small pot of money and dividing it even further. I think that for folks that haven't read the funding request application, you were allowed to focus on 5 broad areas. And what I've seen is that some states chose to focus on a couple,
Right.
whereas some states chose to focus on all of them. I think it's hard to know exactly how CMS is going to evaluate any of these applications, but when you take an already small pot of money and divide it into 5 overall initiatives and then a bunch of small initiatives
with a variety of entities that can apply for it.
Exactly. You've taken an already pretty limited size of money and divided it in such a way that it really can't be used for much big.
No.
It can't be used explicitly to offset losses directly. And then I think one of the other big differences that I've noticed between the Michigan application and some other states is the sort of the lack of specificity in terms of where resources go. And virtually all of the initiatives, rural health clinics, rural hospitals, primary care physician offices, FQHCs, behavioral health units, all of these groups are eligible to compete for funding or to apply for funding. Some explicitly call for partnerships between these groups. That's really common across the state applications that I've seen. But there are states that made it explicit that this pot of money is to go to rural hospitals, or this pot of money is to go to this entity. And so I think with our application, it's a bit vaguer in terms of where that money goes. And there's a lot of different smaller pools. And so I think my concern is that there will be quite a lot of competition for that money, but that very little of it's actually going to end up in the hands of rural hospitals or rural providers even. Large chunks of the money seem to be geared more towards educational institutions, which will be great for developing a rural workforce, but they have to have somewhere to work.
Exactly.
And that's a problem. And things like transportation development, but you have to be going somewhere, right?
To get the services.
And so I think that's all the states have a real challenge on their hands, which is that in that first year you have to spend through the allocated amount of money that you get, or it's gone. And that creates real hurdles for a competitive bidding process, for allocating grants in more complex ways. And some states, I think, chose as a result of that to say, this is where the money is going, to these units only, and we'll have a committee to decide what that looks like. I think other states have opened it up to a variety of different entities, and that I think is more along the lines of what we've done here in Michigan. That I think, in part, the signals from CMS that this is not to be used to overcome the Medicaid losses with these sort of administratively difficult spending timeframes and listed spending goals put states in a really weird spot.
Beautifully said.
And I think that's a really difficult thing to navigate in general. And some states chose to simplify that process by saying this amount of money to the providers, they can figure out exactly what that looks like locally. Other states, I think, are consistent with what Michigan did, which is several different initiatives for many different potential smaller pools of money. If that smaller pool goes to a single place, then that's a sizable amount of money to do something, but then you have a lot of people who are left out.
Correct.
If it's divided across a lot of entities, that's not very much money to do anything with. And so, I think, you're 1 trillion down to 25 billion, 50 billion comparison. I actually think even undersells how small of a chunk of money that really is.
Comes through.
And the other curiosity, and this has nothing to do with the Michigan application, is and more with the notice of funding, was that most states are going to receive pretty similar amounts of money, except for the states that have the 5 largest land areas. And so large chunks of money are being delivered to states
Directly.
like Texas, California, Alaska, Montana. And those states have, well, in the case of Texas and California, there are large numerical rural populations, but percentage-wise actually quite small. Montana is a very small population state, but is going to receive drastically more money than a state like Michigan. And so I think to say that the funding requirements were curious would be an understatement. And I think states have responded in some things, I think, very similar ways. But the primary difference being, in my view, how many small pools of money and the specificity of the named entities receiving that money. And I think Michigan has opted for an expansive application process, as well as an expansive initiative portfolio, which sounds great. But I think on paper, but I think in practice could prove to be quite difficult to administer, and ultimately will lead to smaller amounts of money going directly to providers. And if the concern coming out of the big, beautiful bill was providers in rural areas staying open,
you just accelerated the issue.
This is unlikely to solve that problem.
Not at all. Not even come close to addressing it. And so the train has left the station. Applications were submitted. The CMS director himself gets to review every state's application. There is no clarity whether we'll even be accepted, assuming that we may be. There's a lot of politics to play into that, like what color is the state? And I think we're going to see that come into play. In playing our hand at a very heavy administrative, program that creates a lot of, what we call bureaucracy, does create a concern for rural hospitals like mine to say, are we even going to get that money? So that's first. And we may not. The danger of that is, we all know, it's one and done. There's no reapplication. And for 5 years, it's gone. And that is a grave concern. So so on the heels of that, because it's done, right? We've advocated. We had our committee. We submitted our recommendations. We, as the MHA subcommittee, submitted our recommendations to MDHHS. None of them were accepted or even at all referenced. Very disappointed. But now that's done. And now we talk about, how do leaders like me influence policy? Because the number of people during my conversations on this podcast to discuss with leaders across the country about the critical importance of reaching out to their legislator, it wasn't done. It was almost like that there has to be, this wall. And I want your opinion. How are we going to change this? And I have a belief that we're going to change it by advocacy and getting CEOs engaged, walking the halls of Congress, knocking on doors. But from a political science perspective and healthcare policy, what is that role between hospitals and their governing structures, and how can these leaders advocate for policy to help those hospitals stay open?
It's a great question. My sense is that there will be lots of provider associations across the country that feel this exact dilemma. My sense is that this is a policy discussion that is not going away, despite the fact that the applications are in. There will likely be pressure on Congress to do more or do something else. I know the Save Rural Hospitals Act is being actively considered. That would be helpful. There are policies that, I don't think it's likely that Medicaid is revisited directly in the short term, but I think in the long term that would be revisited and on the table. And so for entities that are able to weather this storm for a while, that will be one option. But in the shorter term, I think the Save Rural Hospitals Act and other potential federal solutions are where the most emphasis needs to be had. I think it's the hospital CEOs, the executives of a variety of healthcare providers, hospital associations, insurance providers, all of these groups we think are really critical to explaining the trajectory of American healthcare policy over the 20th and 21st centuries. And my sense is that a lot can be accomplished by banding together to highlight that the problem has not been solved and offering more tangible solutions. So I think the Transformation Fund was in many ways created, I think, as a response to that kind of advocacy, but done so at least in terms of the application process without the consult of those groups. And so I think focusing on a tangible set of proposals that can shore up rural hospital financing, rural healthcare provider financing is critical. And I think that healthcare leadership is where that has to start. You know, I think a lot of people have a folk theory of democracy, which is that voters get mad and they yell at their politicians and things get changed. That's not really what we see. Voters misunderstand a variety of healthcare related problems. Voters don't have the time of day to engage in this, and they often don't have the kind of information that we have to make a difference. And so I think the pressure needs to be coming from executive spaces and
boardrooms.
Exactly. And I think that it will. Odds are the concerns that you've raised about the Transformation Fund not leading to money directly to hospitals, that's going to come true in a lot of places. There will be places that are coming out okay from this, and those are places that have small rural populations and are still receiving, if their applications are approved, that $25 billion. If politics and discretionary partisan politics plays a role in the CMS review process, my guess is you'll see even more pressure coming from these leaders because it is, I think, left out of a lot of the discussion is that CMS has the right to deny the application altogether, and then no money is coming to a state. That would be worse than the small amount of money that's coming, but for a lot of providers, they probably have shifted from expecting some amount from their state to nothing. And that, I think, increases the urgency that people feel, but also the necessity of getting out there and talking with congressional leaders.
And that is where we are today, sadly. That is the picture. And, you know, when you think about our own congressman made a statement that the failure of hospitals, true story, will be because of the failure of their administration. That is such a terrible statement. You know, the failure of our hospitals are going to be directly linked, and your students will be studying this years after, is going to be the direct link of what happened under this one big beautiful bill, truly. Because we say now that we're raising awareness, but until the Save Rural Hospitals Act is passed, before Grassley, and he's been trying to get off the ground for a decade, before that even happens, how many other hospitals are going to close in the interim? And in the interim of that closure, too many hospitals will find themselves as abandoned places where we can just trace right up to the road here, 35 miles, a hospital that closed over a decade ago. The economic impact to their community, devastating. Economic development halted. It's a university, there's a college town, struggled to recruit students. Parents don't want to send kids to a college where healthcare is 45 minutes away. Businesses don't want to relocate in an environment where if they have a risk, a threat, an injury, you're 50 minutes away from a hospital. And so that is the grave concern is if there's ever an opportunity, I say it's now. You know, we often think, well, let's just wait till the midterms. Can't wait till the midterms. You know, that may be one of the options that are available. But right now, advocacy, education, and what you're doing, which is supplying very, very simple information that you studied and said, this is the pathway that we're headed. And so I guess I want to end today. It's already been almost an hour. It's hard to believe. But I want to end today on something positive because we've talked about all of these concerns and they're real. You know, you've given a charge to leaders and to executives and boards to get engaged, to have those conversations. It's not failed administrators. It's this policy that strips money away from hospitals under provider tax So we can't deliver the Medicaid service in populations where it's 70% or greater. So I want to end with this. You're a professor, and you are looking at very many bright minds and hungry students who are listening to you and who are placing a lot of trust in you and what you're teaching. I'll never forget my political science professor. The one thing he always said to us, there's one thing you can only remember out of this class. It's that all forms of government are local, and you just kind of play that in your mind. And I can remember that it's been a long time ago that, okay, this is a local issue. Okay, it's all a local issue. What do you want to leave your students? And what would you do for them? What are you saying to them to get them charged up for healthcare policy and to understand what their role and relationship is? What is it that you want to achieve with that?
That's a great question. I think it's an especially important one right now. A lot of students in public health are facing uncertain futures. A lot of people in healthcare are facing uncertain futures. Mm-hmm. And what I really try to get my students to see or to focus on when they leave my class is the importance of utilizing their voice, which coming out of the University of Michigan is an elite voice.
It is.
That they're a part of the educated elite. They've gone to one of the best public schools in the country, one of the best universities in the world. And that voice can be used in a variety of ways. And it's important to use the power that you accumulate in your life, the status that you accumulate through your education, through your work, to bring a voice to people that are mostly left out of powerful circles. I really try to get them to think about representing or working on behalf of marginalized members of whatever communities they come from or whatever communities that they care about, and know that with that status that they've achieved, there are things that can be done, that positive change is possible. And one really must commit themselves to living a life that's not only fulfilling at an individual level, but one that focuses on equity, it focuses on reducing marginalization, that provides a voice to the people who didn't get the opportunity to be, at the University of Michigan. And for me, I never imagined that I would be a professor, period, much less one at the University of Michigan. And I try to use my voice to speak for rural communities and the needs of rural communities, for rural people who aren't represented in institutions of higher education the way that some other wealthier groups are, and then in the education space are often considered a less than profitable entity and therefore not desirable. Right. I think it's important to remember to lend your voice to groups that you care about when you have the opportunity to do so. And for people that are concerned about rural health, I think this is a great time to focus on being strategic and persistent with using your voice.
Absolutely. You're engaged in some incredible work, and you're doing an incredible job. I just want to commend you, honestly. And it's a lot of work. It's a lot of, obviously, conversations, and it's frustrating at times because, we are not moving any mountains today, right now, but we are slowly moving some stones, and that's important. And I want to congratulate you for the work that you've done to elevate these issues. And you have been very insightful to me personally, as well as our state association. And I can't thank you enough for that work you've done. So you've given sage advice to your students. Let's end with something that we do here on the podcast. And it's really just asking for a rule recommendation to a listener. So there's someone listening from Texas right now. I know that for a fact. He's a senior executive, and he has had all of his C-suite listening to this podcast, and some of them are brand new. What sage advice would you give them in today's rule setting, what they can do? Maybe it's sage advice, maybe it's just a tip, maybe it's a recommendation, but how do we charge them up, or what would be that advice you would give them?
I think for people who aren't necessarily acquainted with rural places, go and listen. I think there is a lot to be gained from being in a rural place, talking to rural people about what their needs are, what their interests are, what they hope for. And I think when you do that, you learn that there are some modes of thinking in health policy and healthcare delivery that are not in line or not in step with how rural people feel about their own
Truly.
healthcare or their own communities. And that can lead you to avoid making what might be viewed by some rural folks as offensive recommendations. Like, maybe there's no reason to have a hospital in this community.
Yeah.
There's only X number of people.
Exactly.
That's a wildly offensive thing
Very
to say.
offensive.
Everybody deserves access to health care.
That's right.
And at one point in our country's history, the federal government believed that every community should have access to a hospital and took active steps to do that.
Public works funding.
Exactly.
A majority of,
And I think since then we've adopted an efficiency mindset in a lot of different ways that are incompatible with rural access on a variety of fronts. And I think really, in my view, are discriminatory against rural communities and the rural way of life. People that live in rural areas aren't the stereotype that they're often portrayed in the media, and rural communities aren't places where you find folks who are desperate to get out and leave. You find people who love their communities and they believe in them and they want to build on them and preserve them. And just because you like living in a rural area doesn't mean that you should have to pay the price of an hour and a half drive to a hospital or to a primary care physician. And so I hope for the future that we see rural health as not something that must derive profits, but is something that we invest in publicly to overcome that profitability problem, to make it to where humans can live where they want to live with healthcare access and be treated with dignity and not some burden or hurdle to overcome or some place that's undeserving of care.
And you know what? That summarizes everything that we're trying to accomplish. Dr. Shepard, you've done a phenomenal job today at outlining the importance of engagement and rural health sustainability. Thanks for your leadership and for the time that you spent in the studio. We're going to drop your information in the show notes so that way if someone wants to reach out to you, that's okay, right?
Please do.
And they're encouraged to reach out to you. You've done some great work. So thanks for joining us on Rural Health Today. We appreciate it.
Thank you for having me.
And thank you to our listeners for tuning in to Rural Health Today. Catch our next segment, Rural Health News, to stay up to date on current state and rural health every Monday, wherever you get your podcasts. Don't forget to check out our latest updates and resources from Rural Health Today at ruralhealthtoday.com. And make sure you subscribe to the show so you never miss an episode. Until next time, remember the power of rural.